Let us put ourselves in the holy presence of our Lord. Our dearest Heavenly Father, thank you for making all things possible. We are grateful for all the blessings you are pouring upon each one of us, despite the challenges we are all currently facing. Thank you for blessing us today with the wonderful opportunity to meet virtually and learn together in the awesomely exciting webinar. May your blessings of wisdom and guidance be upon us, all through the sharing and impartation of knowledge and skills by our resource speakers, facilitators, and moderators. May all of us learn together, upgrade our competencies, and capacitate us to be the help in the development of our learners' lives and communities in the spirit of your love and generosity. May we now humbly commit every part of this webinar to you as we all bring you the glory, honor, and praises for your kingdom and holy name's sake. All this we pray in the precious name of our Lord and Savior Jesus Christ. Amen.
Through the dreadful darkness, we shall lead the light and lead a path to wisdom. Our will to be our light. To those in pain and suffering, we shall hear a call. With us to care and comfort, compassion above all, to praise the brighter future, bound in unity, the Trinity College of this nation, we shall be, hand in hand, building a stronger nation. This
The Philippine College of Physicians, through the Committee on Media Communication and Health Forum, presents its bi-monthly lay forum to promote the advocacies and mission of the college and its component and affiliate societies. An avenue of accurate and up-to-date conversations with the media and the general public, with timely and diverse topics covering vital public health and medical information, straight from the experts. In a platform that is convenient, accessible, and highly engaging. Welcome to the PCP Health Forum.
And welcome again to this week's PCP Health Forum. Welcome to all the viewers that have attended this health forum. Welcome to our PCP colleagues, fellow medical practitioners and healthcare workers, our very supportive media partners, and all the viewers that are watching this either through our Zoom webinar, our other social media platforms such as YouTube, and Facebook Live, welcome all to this PCP Health Forum. I am Doc Kat Tuhino, a member of the PCP Media Communication, and will be the moderator for today's Health Forum. So for this week's Health Forum, the PCP Committee on Media Communications have collaborated again with the Philippine College of Hematology and Transfusion Medicine in another very important topic. Our topic for today is entitled Spotlight on Thalassemia. So thalassemia is an inherited blood disorder that occurs when the body does not make enough hemoglobin, which is a part of the red blood cell that carries oxygen. When there is not enough hemoglobin, the red blood cell will not function properly and may not carry enough oxygen to the other parts of our body. So signs and symptoms of thalassemia include fatigue, weakness, dizziness, pale skin, difficulty breathing, facial abnormalities, abdominal swelling, and even dark tea-colored urine. So to open us and welcome us into this health forum, may I now introduce the incumbent member of the Board of Regents of the Philippine College of Physicians, Dr. Maalidin B. Birawar, for our opening message.
Magandang umaga po sa inyong lahat. Good morning, everyone. So I'd like to welcome you to today's health forum. Since we started this health forum, marami nang nanonood, especially our patients, at marami silang nalalaman tungkol sa mga sakit po na meron tayong mga Pilipino. And this is a very important tool for us to be able to communicate to you and to educate the public and also other physicians regarding some of the more important diseases that we need to know about. And ang thalassemia po ay isa sa mga sakit na kailangan talaga nating magkaroon ng kaalaman, no? Because it can be mild or severe. At ito po ay compatible with life. So pwede po tayong mabuhay ng may thalassemia. At pwede nga po siyang mild lamang or hindi malala at pwede rin po siyang lumala. At kailangan po nating malaman yung tungkol sa sakit na ito para po baka may mga simptomas na palang nararamdaman yung ating mga kamag-anak or tayo at hindi natin alam meron na palang thalassemia. At nabanggit nga po ni Doktora, ito ay tungkol sa pagkakaroon ng hindi pag-produce ng hemoglobin o pula ng dugo. So balit, marami ho tayong malalaman from our specialists. Sila po yung ating ni-request na magbigay ng lecture ngayong araw na ito para po makarinig tayo ng specialista na makapagsabi sa atin ng maraming kaalaman regarding sa thalassemia. So thank you po for showing interest at sana po magstay kayo hanggang matapos yung ating program this morning. Magandang umaga po sa inyo lahat.
Okay. Thank you, Dr. Birawar, for graciously opening our health forum. So before we start our session proper, may I remind everyone of the rules and etiquette for this webinar. So we will have a Q&A portion for this health forum. So you can type your questions or inquiries about this topic on our Q&A chat box sa Zoom webinar or yung chat box ng YouTube Live or Facebook Live so that on the Q&A portion, our distinguished resource speakers can answer this. So for this health forum, which we all know is about thalassemia, we have not one but two speakers to talk to us on this topic. So our first speaker is actually Dr. Mariel Luis Manuel. Okay, she is actually a member of the Multimedia Committee of the Philippine College of Hematology and Transfusion Medicine. She is a hematologist and her hospital affiliations include ACE Medical Center, Quezon City, Jesus Delgado Memorial Hospital, East Avenue Medical Center, Quezon City General Hospital, and she has various researches on the clinical profile and treatment outcomes of Filipino chronic myelogenous leukemia in a tertiary hospital, It was done in UST Hospital Department of Medicine in 2021. She also had a research on exercise and anemia, a systematic review, and she was awarded the most outstanding research paper at the University of the East Ramon Magsaysay Memorial Medical Center in the year 2011-2012. For our first speaker, may I now welcome Dr. Mariel Manuel to give us a discussion on thalassemia.
Good morning, everyone. I am Mariel Lois Manuel, an adult hematologist. And for today's PCP Health Forum, I will be discussing thalassemia. So thalassemia is an inherited blood disorder characterized by decreased hemoglobin production. It is actually the most common monogenic disease and is frequently found in Southeast Asia, South Asia, the Middle East, the Mediterranean countries, as well as North and Central Africa. Earlier this month, we celebrated the International Thalassemia Day, which is observed worldwide on May 8th. So it's also fitting that the PCP has its health forum on thalassemia this month. So central to the pathophysiology of thalassemia would be the abnormal hemoglobin. So as a quick recall, hemoglobin is a molecule that transports oxygen and carbon dioxide. It is made of 4 subunits. So in the adult, the most predominant form of hemoglobin would be hemoglobin A or HbA. It is composed of 2 alpha chains and 2 beta chains, like in the picture. The alpha chains are colored blue and the beta chains are colored orange. A small percentage of adult hemoglobin would be hemoglobin A2, which is composed of 2 alpha and 2 delta chains. During intrauterine development, the predominant hemoglobin would be HbF or fetal hemoglobin, which is made of 2 alpha and 2 gamma chains. So all other hemoglobin types that fall outside of the normal development would be what we call hemoglobin variants. So in reality, there are over 1,000 hemoglobin variants. Thankfully, the vast majority of them are benign. Only those that cause significant alterations in structure, hemoglobin stability, synthesis, or function would lead to hematologic or clinical consequences. So this table on the right shows the classification of the clinically significant hemoglobin variants. For the purposes of this lecture, we would only be focusing on item 5, the hemoglobin variants that cause a thalassemic phenotype. So all of these hemoglobin variants fall into this umbrella that we call hemoglobinopathy. Hemoglobinopathies may either be qualitative or quantitative. The qualitative ones refer to those that cause an abnormal structure, such as sickle cell anemia, the methemoglobins, as well as unstable hemoglobins. The quantitative hemoglobinopathies result in an abnormal number of hemoglobins, particularly the thalassemia syndromes. So thalassemia would be classified according to the globin chain that is deficient. So for alpha thalassemia, there is diminished or absent production of alpha chains. For beta thalassemia, there would be diminished or absent production of beta chains. These two would be the more common forms of thalassemia, but there are other rare forms such as gamma, delta, epsilon, gamma, delta, beta, and many more. So here is alpha thalassemia. So you have decreased number of alpha chains, and so you get an excess of the non-alpha. Remember that in utero, the predominant hemoglobin would be HbF, which has 2 alpha and 2 gamma chains. So when you have less of alpha, you can get a tetramer of the gamma chains, which we refer to as hemoglobin BART. Hemoglobin BART unfortunately has a very high affinity for oxygen, such that it's unable to transport oxygen because gas exchange would not be possible. This results in severe anemia, hypoxia, culminating into what is known as fetal hydrops. in the adult, wherein the predominant form of hemoglobin would be HbA, which is alpha 2, beta 2. And so in alpha thalassemia, you have less alpha chains, so you can get a beta 4 tetramer. This is what we refer to as hemoglobin H or HbH. So HbH can form inclusion bodies in the red blood cell, as in the picture, and this leads to RBC hemolysis, leading to the anemia that is characteristic of alpha thalassemia. So alpha thal exists in a spectrum. There are 4 alleles that code for the alpha globin chain. If 2 of the 4 alleles are deleted, then that patient will have alpha thalassemia trait. The hemoglobin level may be normal or there may be mild anemia, and RBCs would be microcytic. But all in all, these patients are asymptomatic. If 3 of the 4 globin alleles would be deleted or otherwise mutated, this results in hemoglobin H disease. These patients would have variable levels of anemia. It can be very mild to severe. The RBCs would still be microcytic, and the more severe forms would also result in jaundice and splenomegaly. Lastly, if all 4 alpha chain alleles are deleted, this would result in alpha thalassemia major, also known as hemoglobin Bart's disease. This results in severe anemia and hydrops fetalis. So historically, as we learned in medical school, hydrops fetalis, it proves to be fatal in utero, because the absence of the alpha chains would be incompatible with life. Fortunately now, in the more developed countries, they are able to perform intrauterine transfusions followed by postnatal bone marrow transplantation, which allows patients with alpha thalassemia major to lead normal lives. So hopefully this technology will be available in the country soon. So next is beta thalassemia. So remember that in utero, the predominant hemoglobin is HbF, which does not have the beta chains. So even though you have complete absence of beta chain production, these pregnancies can be carried to term. So you have less of the beta, so you get an excess of the alpha chains. The alpha globin chains, however, are not able to form a viable tetramer. So what happens is, in the bone marrow, these alpha globin chains precipitate, and this leads to intramedullary RBC destruction, leading to a process that we call ineffective erythropoiesis, because there is RBC production, but they are destroyed in the marrow and they're not able to go into circulation. There are some red blood cells that can exit the bone marrow and go into circulation with alpha chain inclusion bodies. These are degraded through time, and being hemoglobin molecules, they release free iron. Now, free iron damages the red cell membrane, leading to RBC hemolysis. So you have ineffective erythropoiesis and low hemoglobin to start with, which is exacerbated by RBC hemolysis. So this characterizes the severe anemia, particularly in beta thalassemia major. So in most cases of beta thalassemia, the fetal hemoglobin, or HbF, is able to persist, which gives a sort of compensatory mechanism for these patients. So similar to alpha thalassemia, beta thal exists in a spectrum. So we have beta thalassemia trait. These patients are asymptomatic. Usually the hemoglobin would be normal and would just show microcytosis. Some patients may have mild anemia. There is also beta thalassemia minor, wherein patients are only mildly anemic with microcytic RBCs, but would still be asymptomatic. There are some references wherein beta thal trait and beta thal minor are lumped together, while there are other references that lump together beta thal trait and carrier, differentiating them from thal minor. But suffice to say that both of these patient groups would be asymptomatic. Next, we have beta thalassemia intermedia, which is midway between the minor and the major, and these patients can present with mild to severe anemia. And of course, the most severe form of the disease would be beta thalassemia major, and these patients present with severe anemia as well as the consequences of it, like skeletal deformities, pathologic fractures, and splenomegaly. There are other rare forms of beta thalassemia that don't really fit into this spectrum, such as dominantly inherited beta thalassemia and the thalassemias that are associated with other hemoglobin abnormalities. So, beta thal can coexist with sickle cell disease, can coexist with hemoglobin C and D, and many others. So, the diagnosis of severe forms of thalassemia is actually relatively straightforward. Particularly for beta thalassemia major, these patients would be dependent on blood transfusion before age 2. So, a lot of them, the severe forms, a lot of them would be diagnosed during their pediatric years. It's actually the milder forms. These patients would be asymptomatic and would probably the anemia would only probably be detected during their first pre-employment examination in their 20s, and these are the diagnostic challenges, which are much more nuanced. So here is an approach that is published in Williams Hematology. So of course, we start with the history, although here in the Philippines, race and family history will automatically be risk factors for hemoglobinopathy. Age of onset of anemia, as well as developmental milestones that may have been delayed, should be noted. However, again, for the very mild forms, we do not expect any developmental delay. For the clinical examination, we check for pallor, jaundice, splenomegaly. These may all be absent in the milder cases. Then next, we of course look at the complete blood count, the reticulocyte count, and the peripheral blood smear. These patients can have mild anemia, especially for the milder forms of thalassemia, but consistent would be microcytosis and hypochromia. This might be easily confused with iron deficiency, which can also present with microcytic and hypochromic anemia. So the difference would lie in the distinction that iron deficiency is a hypoproliferative anemia, so it would result in a low reticulocyte count. So if all of these investigations would lead you to a suspicion of a hemoglobinopathy such as thalassemia, then go ahead and order the hemoglobin electrophoresis. This would show the presence of any abnormal hemoglobins. For the milder forms of thalassemia, the abnormal hemoglobin may occur in small quantities that would not be recognized or detected by hemoglobin electrophoresis. In such cases, we can do a genotyping for thalassemia. But here in the Philippines, the cost of genotyping would still be quite restrictive. So a lot of the hematologists that you know would only be able to perform up to the hemoglobin electrophoresis. So since thalassemia is a congenital form of anemia, central to its management would be, of course, to maintain an optimal level of hemoglobin. First, of course, would be the judicious use of blood transfusions. Remember that not all individuals with thalassemia would be anemic or would be severely so, and not all anemic patients will be requiring transfusion. Folic acid supplementation is also given particularly for patients on a low transfusion protocol or those who do not require transfusion. Second, of course, would be the appropriate use of iron chelation. Thalassemia patients are prone to iron overload. Fortunately, in the Philippines, we have 3 forms of iron chelators. Deferoxamine is given intravenously. Deferriprone and deferazrox are oral forms. And of course, we do regular monitoring for complications and treatment of these complications. Particularly for the chronically transfused patients, we work them up for iron overload. Excess iron is toxic to our organs. They can deposit in the liver and cause cirrhosis. They can deposit in endocrine organs and cause diabetes. They can deposit in the heart and cause heart enlargement and subsequently heart failure. Other forms of treatment would include judicious use of splenectomy. Not everyone with thalassemia would actually require splenectomy. Indications include an annual BT requirement that exceeds 200 to 220 ml per kilogram, hypersplenism, and symptomatic splenomegaly. So these patients that would have an abrupt increase in their transfusion requirements would actually be in the pediatric age groups. So us as adult hematologists, when we get the beta thal major patients, for example, they're already status post splenectomy. Stem cell transplantation is currently the only curative treatment for thalassemia major. And here in the Philippines, it's available in our stem cell transplantation centers. Novel therapies available in developed countries include luspatercept under the brand name Reblozyl. It's an RBC maturation agent that is given intravenously. Gene therapy has also been approved in the United States, betibeglogene autotemcel under the brand name Zynteglo. So hopefully these technologies will be available in the country in the coming years. So what do we have in the Philippines in terms of patient support? So in 1993, Baliketang Thalassemia was founded, and they established the Thalassemia Center at the Fidelmundo Medical Center. In 1994, the Kite Foundation was registered in the Philippines, and they are currently in partnership with a lot of hospitals, including PCMC and the National Children's Hospital. In the same year, Republic Act 7719, also known as the National Blood Services Act, was enacted. This allowed for the strengthening of the voluntary blood donation program in the Philippines in order to support the chronically transfused patients. In 2005, Baliketang Thalassemia reconnected with the Thalassemia International Foundation, and currently the foundation is able to receive donations from the international arena, which it shares to its members. In 2014, pursuant to the administrative order, the hemoglobinopathies were now included in the expanded newborn screening program. This includes alpha and beta thalassemia, hemoglobin C, D, and E, as well as sickle cell disease. And as of 2020, we now have full PhilHealth coverage for the expanded newborn screening. And hopefully sometime in the future, we can have a Republic Act for thalassemia, similar to how we have a law for our cancer patients in order to support these patients. And with that, I end my lecture. I would like to invite everyone to come observe World Blood Donor Day. This is celebrated every June 14th, and here in the Philippines, we will have simultaneous blood donation activities across the country. So visit your local hospital, visit your local blood center in celebration of this day. Maraming salamat po.
Thank you, Dr. Manuel, for your very comprehensive and very informative discussion on what is thalassemia, how we diagnose thalassemia, management on it, and the milestones on patient support with thalassemia. Since thalassemia is an inherited condition that can be diagnosed from childhood, our next speaker will be talking about how we transition care of a pediatric patient with thalassemia to adult care. So our next speaker is Dr. Carlo Francisco Cortez. He is an active consultant in the Perpetual Health Medical Center Las Piñas and Rizal Medical Center. He had his fellowship in hematology at the University of the Philippines Philippine General Hospital. He also had his residency in the Department of Medicine at Makati Medical Center, and he was a doctor of medicine at the De La Salle Health Sciences Institute at Dasmariñas, Cavite. So without further ado, I would like to call on Dr. Carlo Francisco Cortez for our next topic on thalassemia, which is transition care.
Good day. First, I would like to thank PCP and PCHTM for inviting me to talk about this topic. I'm Carlo Cortez, and today I'll be presenting a brief discussion of transition care in thalassemia. So what is healthcare transition? Healthcare transition is the process of moving from a child to an adult model healthcare with or without transfer to a new clinician. Why is this important? Transitioning from adolescence to young adulthood in itself is a dynamic experience, wherein a lot of changes occurs at varying stages of development. And if you add to that a chronic illness such as thalassemia, this can increase anxiety and burden not only to the patient but also to the family. Today, I will highlight the importance of transition care as a process to tackle common barriers in transition, familiarize ourselves to the 6 core elements of transition care, and provide some difference in the approach of care from a pediatric to an adult-centered care in relation to thalassemia for us to better take care of our patients. First, I would like you to meet Lucy. She's an 18-year-old female, known case of thalassemia, currently beginning her first year of college with a previous history of blood transfusion while she was in grade school. She has regular follow-up with her pediatric hematologist at a government hospital and is currently planning to continue care with an adult hematologist. This case may seem simple, but if we try to put ourselves in Lucy's shoes, she may be thinking, sino magiging doktor ko? Saan ako magpa-follow up? Ayoko lumipat kasi sanay na ako sa doktor ko. Bakit kailangan lumipat? Pwede ba ako bumalik sa dati ko na doktor? These are but a few common barriers perceived by the patient in the process of transitioning from pedia to adult-centered care. There are pedia and adult clinician barriers as well. But for today, I will focus on perceived barriers by patients and parents, which can be summarized into 3. First, the fear of new healthcare system and our hospital. Dito pumapasok yung concern ni Lucy na ayaw lumipat sa bagong doktor kasi sanay na siya sa pedya niya. Hesitance in change. Sa nakasanayan na, not only in the doctors but also in the location. Learning new commute going to and from follow-up can be bothersome. Second, inadequate planning. An example would be inadequate preparation of clinicians in transition process, katulad ng walang mga copy or kulang ang mga medical history and laboratories or iba pang mga importanteng dokumento na makakatulong once magkonsulta ang pasyente sa adult doctor. Or hindi interesado yung pasyente sa kanyang kondisyon dahil sanay na yung magulang ang nag-aasikaso ng lahat para sa kanila. Lastly, system difficulties. Mahirap maghanap ng adult doctor na magtutuloy ng pag-aalaga sa pasyente, lalo for thalassemia patients, na limited lang ang hematologist sa buong Pilipinas. Isa pang factor ay ang coverage ng gamutan. Malaking pagbabago ang nakukuhang suporta ng pediatric population kumpara sa adult patients at mula sa government support to private care. So how do we as clinicians overcome these barriers? This is through implementing an adequate healthcare transition program using these 6 core elements throughout the follow-up of the patient. And this should start as early as 12 years of age with their pediatric doctor. First, by introducing a transition policy, where the members of a transition group form a transition care policy to introduce both the patients, parents, and guardians regarding transition, the approach to care in terms of privacy and consent, and subsequent adult care. It is vital to educate all the staff about the practice approach to transition and distinct roles of the youth, the parent, caregivers, the pediatrician, and the adult healthcare team in the transition process, taking into account cultural preferences. It is also important to display the transition care policy guidelines somewhere accessible in the practice space for easy reference upon discussion and sharing. The second core element is transition tracking. This is to establish a criteria and process for identifying patients that would qualify for transition. We develop a process to track their progress, which is best done by integrating electronic medical records whenever possible, and eventually form a registry of patients. The third core element is transition readiness. This encompasses conduction of regular transition readiness assessments beginning at the age of 14 to 16 to identify and discuss issues for self-care and how to use healthcare services available. There are some validated assessment forms for general transition. These forms you see are tailored for thalassemia patients. After which, we may offer education and resources on needed skills identified through the transition readiness assessment. The fourth core element is the transition planning. This consists of development and regular update of the plan of care, including readiness assessment findings, goals, and prioritized actions, preparing medical summary and emergency care plan, and if needed, a condition fact sheet and legal documents. This is when we introduce the patients for legal changes in decision-making and privacy and consent, as well as self-advocacy and access to other information. The timing of transfer from pediatric to adult care is also discussed, especially if other subspecialty care are required. Assisting patients in identifying adult clinicians to provide social worker support, self-care management information, and community support services as well. Obtaining consent from the youth, the parent, and caregiver is also important for release of medical information, taking into account cultural differences. The fifth core element is the transfer and integration. This is the completion of transfer package, including all the necessary information containing the pertinent medical summary, laboratories, and other legal documents. This also confirms the date of the first adult clinician appointment. We prepare a referral letter with the transfer package, send it to the adult clinician, and confirm the adult clinician's receipt of the transfer package. We coordinate with select adult clinician about pending transfer of care, and confirm the pediatrician's responsibility for care until the youth is seen by the adult clinician. The transfer of the young adult is ideally done when the patient is stable. The sixth core element is transfer completion. The adult clinician coordinates with the pediatric counterpart to update regarding the status of the patient and their transition process. This may be done after 1 month, the 3rd month, the 6th month, or the 12th month, depending on your communication. We also elicit anonymous feedback from the youth, their parent or caregiver on their experience with the transition process to build ongoing and collaborative partnerships with adult primary and specialty care clinicians and improve upon the transition process. So is this really necessary? It's a lot of additional work, but will it change the management for the patient? Yes. As adult hematologists, we have a lot of adolescent patients who consult us without adequate understanding of their illness. Some may have incomplete records. Some even do not continue follow-up as adults once they graduate from pediatric care. But proper healthcare transition help in the continuity of providing adequate care in our thalassemia patients. Summarized here are just a few examples of differences in the pediatric and adult-centered care in thalassemia to further emphasize the importance of continued transition to adult care. In terms of transition, both will have a personalized hemoglobin threshold but will differ in that pediatric focus is on achieving normal growth and development, while adult focus on preventing fatigue, pain, and long-term complications. Both pediatric and adult care may include iron chelation in controlling and preventing iron overload, but is more common among adults. Endocrine focus is on growth and puberty in pedia, while adult focus is on development of complications such as diabetes, hypogonadism, and osteopenia. Pediatric and adult patients may develop hepatic fibrosis, but another important thing to consider among adult patients are screening for hepatocellular carcinoma in select patients. While cardiac complications are much more commonly seen among adult patients, such as congestive heart failure, arrhythmias, and pulmonary hypertension. Renal tubular acidosis is common among pediatric population, while monitoring for the renal function and nephrolithiasis is more common among adults. Psychosocial support also differs, where priority is on family, school, play for young patients, while adult care would focus on autonomy, including career, relationships, and sexuality. Of vital importance is proper education regarding genetic counseling for parents of young patients who wish to have future children, as well as for young adult patients who would eventually desire to have a family. The main difference among this is our goal for the patient, where pediatricians would try to achieve normal childhood experiences, while adult clinicians would target a fulfilled adult life. Lastly, for our patient Lucy, once she has completed transition care and have developed rapport, I cannot emphasize enough the importance of proper education regarding genetic counseling, mainly their proper understanding of the chances of them passing on an inherited disorder to their child. I usually educate my patients if nagplaplano sila, magkaanak in the future, importante na matest din ang kanilang asawa or magiging asawa. Dahil if malaman na pareho silang may thalassemia, kahit na trait lang, ang chances na mapapasa nila yung sakit na ito sa kanilang anak umaangat to 50%. Maliban dun, may 25% chance na malalang form ng thalassemia ang may papamana nila. I use this and guide them accordingly so long as they understand the risk, and if not, I provide other options in terms of family planning. With that, these are my references, and belated World Thalassemia Day. Thank you.
Thank you, Dr. Cortez, for giving us an overview of what is transition care and how we go about transition care of a pediatric patient with thalassemia to adult care. So now we go on to the next portion of this health forum, which is the Q&A portion. So again, for those who are watching us in Zoom or in YouTube and Facebook Live, if you have any questions, please type your questions in our chat box or at the comment section so we can answer these. So may I now call on Dr. Manuel and Dr. Cortez for this Q&A portion part. So I think, let's see if we have any questions now. Sige, I think I'll start the ball rolling. Doc, we talked about, Dr. Manuel, I think I can pass this question to you. We have patients, diba we say that we have patients that, for the general audience, I think, diba, patients with thalassemia would also have anemia. So is yung mga iron supplements, is it still beneficial for patients with thalassemia, or we don't give iron supplements to them? I think yun po.
Thank you, Doctora. That's actually a very common question from our patients. So, iron is a supplement, and ideally, we give this to patients with documented iron deficiency. So, having thalassemia does not preclude you from also having iron deficiency. While it is true that there is increased iron absorption, particularly in the more severe forms of thalassemia, female patients can still have iron deficiency if they have heavy menstrual bleeding. So we don't give it routinely. Hindi porke anemic, hindi porke nasabihan na may thalassemia, kailangan agad ng iron. That's not always the case. So you still have to investigate. There will still be cases wherein iron would be appropriate for thalassemia patients, but routinely not really.
Okay. Thank you, Dr. Manuel. So not all patients with thalassemia should be given. So we have to investigate what is the cause of anemia, I think. So it for us in order to give if iron supplements is beneficial then. Okay, thank you, Dr. So we have few questions na in the Q&A from I think our audience participant, Dr. Samantha Hope C. When is stem cell therapy absolutely warranted? Since even if it is the only cure, it is very expensive. So I think kay Dr. Tess or Dr. Manuel, anyone can answer that, I think. So is stem cell therapy warranted? Absolutely warranted, and if it is the only cure, because it's very expensive.
So currently, it's the only curative intervention for thalassemia major. It's really only offered for those who are dependent, meaning dependent on blood transfusion, meaning if they do not get their routine, it's usually weekly or every couple of weeks. If they don't get that transfusion, they will get severe clinical manifestations or even succumb to death. And so only these patients are offered stem cell therapy. Again, the cost is still rather restrictive in the Philippines. So a lot of these patients, the beta thal major here in the Philippines, they just undergo a hypertransfusion program.
Okay, thank you, Dr. Ra, for that answer. So we still have
we do have patient authorized healthcare. That would be much.
Sorry, nakakat si Dr. Manuel. Dr. Can you repeat that last part? I think nakat yung what you said in the.
Sorry, my internet connection is quite unstable.
It's okay. It's okay.
So yeah, so hopefully if we can have more government support for our patients, then maybe stem cell transplantation can be covered in the future.
So for more severe types yun given, Doctora. Yes.
Yes,
okay,
for
now. And hopefully we could get yun nga, government support and funding for these patients. Okay, so we have a few more questions. Okay, they are coming in. Okay, so from Doc Nemi or Dr. Nemencio Nicodemus, his question is, for patients with diabetes and thalassemia, can we still use HbA1c as an accurate parameter to monitor long-term glucose control?
Yes.
Dr. Tess, yes.
I may. That's a very good question. No? Actually, I would think they would depend on case to case depending on the severity of the patient. No, kasi usually we actually have cases wherein you incidental finding upon doing HbA1c. That's the time where you find an abnormal hemoglobin pattern as well. But if it's mild form of thalassemia, HbA1c can still be used as a form of monitoring in terms of their diabetes control.
So for mild patients, we can still use HbA1c, Dr. Test, right?
Even if severe forms din po, in terms of monitoring control, dapat aware lang in terms of proper interpretation.
Okay.
Na pagbasa ng HbA1c.
Thank you, Dr. Cortez. So we have a question from an anonymous attendee. So, good day, doctors. Thank you for the comprehensive lecture. I'm sorry if I have missed this, but I would like to ask yung purposes of pre-employment clearances. I'm pretty sure ang dami yung questions about this as well. So, if a patient is suspected to have thalassemia because of a CBC, but is asymptomatic and has unremarkable PE, do we need to still refer to hemo for clearance? Or what are the steps to do when presented with this case? Salamat po. Okay. Thank you for that question po, from an anonymous attendee. Siguro Dr. Manuel muna and then Dr. Cortez. I think you can both answer po the question. Yeah.
For non-anemic patients, for example, the only flag in the CBC would be the red cell indices microsymptomatic. Clearance would be straightforward, but it really ultimately depends on the employer. If the employer would want a hematology clearance simply because there's a CBC flag, then that patient would require hemoconsult. But other than that, wala namang anything to clear if the patient isn't even anemic. So that should be straightforward.
Okay. Dr. Tess, your inputs regarding pre-employment clearances on thalassemia?
Yes, I would agree with Dr. Manuel, especially asymptomatic patients. If we do get cases of referrals of such patients, what I usually do is just do a PBS just to do an initial screening. If mukhang may possible thalassemia, I would clear the patient, then just advise them if they want to do further workup, to do hemoglobin electrophoresis, and then
in order to suppress the ineffective erythropoiesis. So they might not really have any benefit to folic acid supplementation. It's the patients on low transfusion or zero transfusion that would require folic acid supplementation. We give it because there is increased erythropoiesis, say with thalassemia, hemolysis, and so the marrow tries to compensate by doing more and more erythropoiesis. So that's what we give the folic acid for. And so for as long as the patient has ongoing hemolysis, the patient is anemic, you can safely give folic acid.
Thank you, Dr.
Cortez, if you have anything to add.
Yeah, Dr. Cortez, yes, po. Your inputs on this. Po.
Yes, same. I would agree with Dr. Manuel again. Usually, the ideal dose is a low dose, 1 to 2 milligrams. But if it's not available, we can give the 5 milligrams only for the certain patients who would require it.
Okay, thank you, Dr. and Dr. Manuel. So, yun nga, we can give it to those with those who have low transfusion, who are not having transfusion. We can give folic acid once a day. Tama po, once a day.
Advise the parents. No? So, my tendency that either the patient does not care about his or her illness, and the mother would prefer yung care ng pediatrician once they get compared to an adult hematologist na more of sanay sila na individualized care, they prioritize the patient first over the parents or the relatives. No? Nandun yung madaming barriers in transitioning, but with the help and proper coordination with a pediatric hematologist, hopefully ma-lessen yung burden with transition.
Thank you, Dr. Tess. So, last two questions before we end, and if you have takeaway messages. So, from Dr. Samantha C. So, what is the role of a primary care physician like family medicine in patients with thalassemia, and when do we refer to hematologists? Yes, po.
Well,
Dr. Tess, yeah.
Yes. Primary physicians can still manage so long as they know how to. Important would be like before with regards to the issues of iron supplementations. Not all anemias will require iron supplements, and not all anemias and not all thalassemia patients will require folic acid then. So at least be wary lang in treating everybody with iron supplements, because especially in thalassemia, if they get overtreated with iron supplementations, they may have iron overload, which would complicate their case. No.
Okay.
So in terms of primary care, as long as they know, or if they're not familiar with thalassemia care in general, it's often easy enough to refer to any hematologist.